Olá, amigos. Bem-vindos a mais um episódio do Clube da Artéria. É um grande prazer ter vocês aqui conosco hoje. Gostaria de lembrá-los de curtir a nossa página no YouTube, tocar o sininho, isso nos ajuda muito. Hoje nós temos uma participação especial. Vamos receber no Clube da Artéria o Dr. Martyn Knowles. Dr. Martyn Knowles é professor associado da Universidade da Carolina do Norte e diretor médico de cirurgia do Rex Hospital. Welcome, Dr. Knowles. It's a great pleasure to have you here with us at Clube da Artéria.
Happy to be here. Thank you for the invitation. Excited to be here in Rio de Janeiro as well.
Eu sou Bernardo Massière, host do Clube da Artéria, e temos também como host o Dr. Arno von Ristow.
Bom dia a todos. Sejam bem-vindos. Vai ser uma entrevista muito interessante, um pouco diferente do usual, né?
Sem dúvida.
Hoje, sobretudo, um assunto muito palpitante, que é a trombose venosa, a embolia pulmonar, as novas diretrizes agora que estão sendo apresentadas na literatura.
É um tema muito palpitante, um tema que gera muita dúvida e muito debate. Então, vamos começar. So, Martyn, again, thank you very much to come here with us. This topic, DVT and proximal DVT, especially NPE, it's a huge topic. There are people with a lot of doubts nowadays, still nowadays, which the better, which will be the standard of care, what we can do better for our patients. Sometimes people still don't offer on some institutions what the technology can still nowadays offer to them. So we would like to start talking nowadays when the patient arrives in your institution with proximal leg edema. What is the protocol at the ER? They already involve the vascular surgeon in the initial evaluation. How does it work in your institution?
Yeah, I think what mostly happens where I am, and probably majority of the U.S., is that they'll get some sort of imaging studies really to confirm what's going on prior to us being involved. So they don't call us initially. A little different in the States is that we don't do the ultrasounds ourselves. We have technologists that will do those. So they'll usually put in orders for a leg ultrasound. Sometimes if they're very concerned about the amount of swelling, they might put in a more proximal, iliac or IVC ultrasound as well. Once they've confirmed the diagnosis, then typically they'll call us. It's not uncommon with proximal DVTs that they'll also check for pulmonary symptoms as well, and often we'll have gotten a CT scan of the chest to rule out a PE as well, because we know there's just such a high rate of PE with really proximal DVT. But generally, we have gotten involved once they've started anticoagulation, if there's no contraindication to it, and then they have imaging findings that confirm that there's a clot. We get a lot of transfers as well from smaller hospitals and surrounding areas, so we already know that we have the diagnosis at that point, and we can kind of help coordinate the care. But that's usually when we get involved, and it's always that question is this someone we're going to do conservative management and anticoagulate? Is this someone that we're thinking of, admitting and doing a procedure right away, or is this someone that we think, maybe we put them on anticoagulation, we watch them for a couple days, and then maybe think about treating them at that time? And I think that's, at least in my mind, the question going through my head when we get called about it.
And we try here in our hospitals to explain to the clinicians at the emergency and the radiologists that when looking for when asking for a PE CAT scan to extend the CAT scan to abdomen and pelvis in order to investigate, to search for pelvic thrombus and proximal thrombus. Do you do something like that at your institution?
Yeah, if we get involved early enough and we can let the radiologist know that we're interested in that, they're usually able to do exactly that. They'll separate it out and have sort of a venogram portion of it within the abdomen for us, which is really helpful. If not, and if it's just the emergency room physician has ordered it, a lot of the time it's just the chest, which is a little unfortunate. And sometimes either we have to look for alternative imaging, re-image them if we need to, which is not optimal. But it is very helpful to have that imaging. I think these days, we find it's not uncommon that you find pelvic masses, you find other pathology in the abdomen that, really changes the management of these patients. So I think it's, to your point, it's really important to know what's going on.
Mm-hmm. The first ATTRACT trial, I think that make a lot of, create a lot of doubts in that field of the proximal DVT. That's the main point that we need to talk here, because the traditional treatment, it goes very well for below the knee and distal DVT. But the issue is the evolution of proximal DVT, because in general, those patients are not well evaluated when treated clinically. In general, those patients got a lot of symptoms, restrictions of normal life that are not get into, are not observed and are not valued when people discuss the importance of treating proximal DVT. In general, those patients got restrictions. It's difficult to return to normal life after that. And Dr. Arno started doing that, started noticing that kind of thing and started treating those patients a long time ago. He started doing with open surgery. Could you talk for us about that?
Yes, we started to do venous thrombectomy in the iliofemoral veins in 1977. Yeah, so it's almost 49 years now. And with open surgery in the groin, and that changed a lot. Now it's a lot more, I think it's more effective. And one of the most important issues that I believe that change in this treatment is that you don't have to stop the anticoagulants. Because that was the Achilles heel of our treatment. We could remove the thrombus, but then you had to stop the anticoagulants, and then partially at least it would rethrombose. And now you take the patient to the OR or to the angio suite under full anticoagulation. You do the procedure under full anticoagulation, and the patient leaves the procedure room fully anticoagulated.
It's funny, though. We went from open surgery and stopping anticoagulation to one of the problems with the ATTRACT trial that we went so far in the other direction with thrombolytics and the dangers of thrombolytics. So we went from stopping anticoagulation and rethrombosis to high risk of bleeding and issues which really ATTRACT highlighted was that, was the benefit in, avoiding post-thrombotic syndrome, important enough with the bleeding risk that we had? And ATTRACT said, not really, no. And so it's funny that it's kind of gone both ways, and we now have sort of landed in the middle, it seems.
Yeah. I see that made a big change. And nowadays, you can do all this without any thrombolytics, in most cases, or using smaller doses that will not have a systemic effect so intense.
Yeah, and I think that's the main criticism of ATTRACT was, if you look at the subgroup of really true iliofemoral DVT in that subgroup analysis, there was a slight benefit to a reduction in PTS with treatment. The cost effectiveness of that was not found because, ICU stays, long thrombolytic therapy was not justified. And I think what it speaks to is that ATTRACT did answer the question, but really for a very heterogeneous treatment group, meaning you could have had a whole variety of different treatments. And really at that time, that came out in 2017, I think. The devices that we use now are nowhere near the devices we were using at that time, and they've advanced so much. So I think ultimately that evaluated at a point in time, and I don't think it's a good evaluation of sort of where things are now. There's a gaping hole, though, in terms of research and in terms of what we should do and how we should do it, because I don't think we have a good answer. We have those trials, but we don't have very good, contemporary trials looking at this. And I think what's interesting is people are looking at it. Inari are looking at the Defiance trial and looking at, a prospective trial looking at this, and mechanical thrombectomy alone, which I think, avoids the bleeding risk, and hopefully we'll see, similar results to what they saw in Clout. There's the Bolt trial. There are other trials coming through, but, to your point, it's been sort of a wasteland of trials that don't really support at least comprehensive treatment of all patients, I think, with proximal DVT. And I think that's the key, is it's not an anatomic diagnosis to treatment, meaning they have an iliofemoral DVT, I think we should treat it. You really have to take so many of the factors you mentioned. What's the likelihood that they're going to get back to work quickly? Does that play into it? What's their quality of life pre-DVT, and what could we get it back to? And, honestly, I don't think the trials did a very good job of looking at quality of life and return to work and cost effectiveness. So we do have a long way to go to, I think, justify what most of us think now is the right thing to do. But at the same time, I think the data is very clear of one thing, and that's there shouldn't be a blanket approach to treatment for everybody.
Mm-hmm.
Yeah, I agree. And I think we need better design trials.
Yes.
Yeah. The ATTRACT trial got a great problem. It mixed people with proximal and distal DVT. I think that was a big Achilles heel for the trial. Mm-hmm. And we need trials evaluating quality of life after mechanical thrombectomy, comparing with conservative treatment. Because nowadays, I can talk here in Brazil, I think in most of hospitals all over the country, conservative treatment is still the standard.
Oh, really? I'm sure of that.
Yeah. I think that's not just here in Brazil. I think that's also in the States. There's a lot of physicians who saw ATTRACT and said, well, I don't believe this. I'm still going to do what I think is right. And then there's a lot of people that got very nervous saying, I don't think the treatment I thought was the right thing to do is now justified. And then there's a huge proportion of people that just go, I think we just treat them with anticoagulation and they all seem to do fine. I don't think that's the case. The problem is, we need to study it better. And I think it's not, I'll one up in terms of, I think we need to design it better. I think we need to look, we don't know what type of anticoagulation or antiplatelet therapy to do afterwards. Everyone's all over the board on that, so we don't know how much that plays into it. I think we need longer term outcomes, not just patency after the procedure. We need 6-month, 2-year quality of life data. How many return to work, how many developed venous ulcers or wounds, how many developed venous claudication. And I think one of the things that they've never really looked into in any of the trials is how important the profunda femoral vein and the common femoral vein are actually to the likelihood of you developing post-thrombotic syndrome or the avoidance of it with treatments. And a lot of now treatments that I'm doing, I'm focusing equally as heavily on the iliac segment and the IVC as I am actually into the profunda as well. Femoral vein, is one of those things. If you're there and you can fix things, it's great. But that's not ever really as important as I think that really the inflow from the profunda vein. We learned. I trained at a place where we did all the neo-aorta iliac system, the Claggett procedures. So we would take femoral popliteal vein and reconstruct aortic procedures all the time, and people did fine as long as their profunda vein was fine. And I think having quality inflow with the profunda vein is part of that. And I don't think any of the trials have really looked anatomically into all these different things to try and really, identify the right patient. I don't think we can do what ATTRACT did, which I don't think they did well, which was they said, I think they got too far in front of their skis. They said, well, we think this is going to work so well. Let's try to push this and see if we can get approval and show people that distal DVT intervention works. And not only did it not show that, it showed us that iliofemoral DVT maybe wasn't of benefit. But they clumped in so many different types of interventions, so many treatment modalities, so many, just any patient. They didn't look at any factors. I think we really have to design those trials much, much, much better to get a real true answer.
Yeah, I really agree with you. And if a patient arrives today in your department with proximal DVT, what is the protocol? Which exams do you submit the patient, and how do you evaluate if you do surgery or not? What's the protocol?
Yeah. I think you're highlighting an important part, which is there's not a defined protocol that I think we all have. I have 7 partners in my hospital, and we probably all do it a little differently. We probably all end up at the same place, but we do it somewhat differently. Generally, again, we want some imaging modalities to prove that there's a DVT and it's where we think it is. So starting with a lower extremity ultrasound, probably getting a CT imaging, axial imaging of the abdomen. I do think that chest and ruling out a PE is important in those folks just from a length of treatment standpoint in terms of anticoagulation. But generally, once we have imaging and we've confirmed it, we'll start anticoagulation if they're not already on it, or we'll transition them off of their oral anticoagulation onto what we used to do was unfractionated heparin, and now we're doing low molecular weight heparin, Lovenox, which is now sort of shown to be probably better, and that's actually been changed in the PE guidelines in 2026 with the AHA in terms of focusing on Lovenox rather than unfractionated heparin, because they showed such a low number of people actually get to therapeutic numbers on unfractionated heparin. So we've shifted to low molecular weight heparin. And, again, to your point, that's going to Lovenox knowing we're probably thinking about a procedure and a treatment, and we're okay with that compared to having not being at an adequate dose of unfractionated heparin. But that's where we'll start. And then really it's a good physical exam, looking at them, seeing how swollen they are. Unlike what I think social media these days and, TikTok and Twitter tells us that everybody has phlegmasia, it's pretty uncommon. Everyone has phlegmasia, but no, they don't. And so, there are obviously phlegmatic patients, and I think that's very different. But majority of patients, it's, okay, well, they're sitting in a bed. They've probably had their leg propped up and been in this bed for a couple hours because they've been in the emergency room. I stand them up and I walk them a little bit and see, how are they able to get around? How are they able to function? If they're a normal functioning person and now they're hobbling around and they can hardly take a couple steps, that's really important information, I think, to help guide, that this person would likely benefit from a procedure versus, sometimes you see these gigantic clots and their leg might be a little swollen, or they were saying, I've got a little bit of ankle pain, and they have very mild symptoms. Those are the people that you really have to scratch your head and go, is intervention on those people the right? So I think the physical exam is really, really an important factor. And then I like to know, their age and, what were they doing prior to this? The number of sort of, 80 to 90-year-olds that we get called for that are actively having a cancer treatment and have a DVT. That's a totally different part. That's where I think we have to very carefully pick and choose who we intervene on.
Yeah, I really agree. Physical exam is most important, one of the most important parts of the judgment here. Mm-hmm. And for me, the intervention got a very important role on the future of the patient. Mm-hmm. A small part of those patients arrive in the hospital with phlegmasia, yeah, but there's a very high incidence of venous claudication mm-hmm. in patients that stay with the proximal venous tract occluded. Mm-hmm. And after deciding to treat the patient, which access do you prefer? Mm-hmm. How do you choose devices?
Yeah. I have generally gotten away from catheter-directed thrombolysis as a first line. I just don't do it very often. I do it really as maybe a bailout if I'm not successful, and I'm really a mechanical thrombectomy first interventionalist at this point. I'd say predominantly what I use is Penumbra, and now with their CAVT systems, their 16 French system, that's most often what I'm using in those cases. I think where I access is dictated by what I think is going on. I used to do 95% of these from the ipsilateral, so same leg, put them prone and do popliteal access or lesser saphenous access, and I would treat all the way up, and then if I needed to stent, I would stent in one session for a iliac compression lesion. And I've gotten away from that. I've started actually doing a lot more internal jugular access now, and a lot of that is what I mentioned earlier is I'm very interested in the profunda vein, and a lot of times there's clot within the profunda vein as well. And I feel it's really important to really get in and clear that out. I can still stent from the jugular, making sure that, it's very hard to come up and over and get a really good stent that way. And so either, prone, still do it sometimes, or internal jugular is more common now. And that way, if I want, valves sometimes are a little bit of a problem going that direction with the veins, but often they're kind of blasted open because of the clot. So it's usually fairly easy to get down, as far as you need to down the leg if you want to get into femoropopliteal area, but also to get profunda, get a good iliac clearance, and then you can stent at the same time. Sometimes I'll go contralateral and go up and over with it as well, but I do know if I'm picking that if there's an iliac compression lesion, generally I'm not going to be able to treat it at the same time, and I'll have to anticoagulate them and maybe bring them back in a couple weeks to stent it. There's some people that preferentially like to do that. I've always tried to do the thrombectomy and stent if needed at the same time. But I think there's no right way to do it. I think every patient's a little different. If it looks like clot starts in the external iliac and goes down, I don't think it's unreasonable to do a contralateral access and come up and over and treat it that way, because likelihood is you're not going to have a proximal compressive lesion. So it's a little bit different for everyone. Case by case. And it also depends. If you get the feeling that someone's just not going to be able to tolerate a jugular access, that might not be the best case. Or if they're very large and you think having them prone is going to be problematic. I do also think if there's a chance, if they have IVC associated thrombus as well, I preferentially like to put a filter in for a lot of those cases. I don't do it for just iliac and down, but if they have IVC clot, generally I will consider putting a filter in at the time of the procedure, so jugular makes a lot more sense for me to do that as well. There are some devices that you can place from the popliteal, like the argon filter you can place from the popliteal vein, but it is really a case-by-case basis.
When you detect compressions on the left iliac vein, how do you judge which stent to use? How do you do the sizing of the stent?
Yeah.
Which stents are available in US right now today?
So, couple parts to it. I think in the US, it's probably standard of care now to use IVUS to help with deciding on sizing. The video trial showed us that really venography you can underappreciate the size of the vein. And so in the States, I know it's a little different here. In the States, I would say it's standard of care to use IVUS to help guide. And you can get really good information as to what the degree of compression is and what the normal size of both the common iliac and external iliac vein are then for sizing. I never place short stents in just the common iliac. I extend them all the way down into a good amount of external iliac. And so I'm equally as interested in knowing the size of the external iliac as I am in the common iliac there as well. I think IVUS also helps you guide where the proximal extent of that compression is, and knowing how far up into the cava you sometimes need to go. I think one of the biggest problems we have in all of these treatments is how we deal with the confluence, the iliac confluence. And, sometimes IVUS will show that you really have to have a stent that almost pushes all the way over to the other side, which we know can be problematic. A little less so with open cell stents than it was with closed cell stents, like the wall stent in the past that showed, 10% contralateral occlusion. But you have to go proximal enough that you get the lesion. If you don't get the lesion, you're just going to be back. Again, you're going to have now an occluded stent. So IVUS is very helpful there. In the States, wall stent was used forever before there were trials. And then we had the Vivo Cook stent that came out, and that's available. There's Medtronic Abre, and then there's the Bard Venovo stent that are all, available. The Medtronic stent has not had any issues whatsoever. The Bard stent was taken off the market and then kind of came back on, and so there's some concern from physicians on that side. So I would say majority of people are probably using the Medtronic Abre stent at this point. In general, for sizing, there's like anything in what we do, everybody disagrees on it, but generally I like to get sizing of the common iliac vein and the external, and I take the average between sort of two orthogonal sort of distances. And usually I'll upsize about 2 millimeters from that average size for there. Or, if it's very, very circular, the vein, obviously then I'll just take one measurement and really just upsize it a little bit. If it's between sizes or I'm not quite sure what I want to do, sometimes I'll just upsize. If I'm putting a 14 stent, I might balloon with a 14 balloon as well, rather than 14 stent to maybe balloon with a 12. But I think the key is just to make sure you've oversized enough to make sure that you don't have embolization of the stent. I think it's much less likely now with these, self-expanding true venous stents than it was with wall stents, which were, just really hard to place in the right area. And then obviously, I think just based on how they work, that sometimes they could move, they could embolize. And, I think we had some over and undersizing issues. So in general, about 2 millimeters upsizing for those.
Just a curiosity. When you do the access to the jugular vein, you pay a lot of attention to the profunda femoris, but also to the hypogastric vein. You can easily enter it.
You can easily enter it. And so, yeah, I will say if the scans have shown that there's clot there, I think it makes much more sense, my opinion, in taking care of the iliocaval segment, common femoral vein, and then profunda, and any of those big inflow veins into that iliac confluence, I think is important. So, yeah, I think hypogastric makes sense as well.
That.
Yeah. And, typically it's not a huge amount of clot.
Because you usually don't do it.
Yes.
Because we normally we do jugular access also, but we are using now the aspiration devices only recently.
Yeah.
And the other devices you cannot do an effective
exactly. And I think honestly,
thrombectomy
why? And I think that's one of the benefits of the aspiration devices is with, like in Penumbra's sense, with the X-torque or the H-torque, where you have sort of the ability to direct. I often don't even use a wire to actually access down. I'll just sort of turn the catheter and get in. And, a lot of the time you're able to get into these vessels that we used to not be able to get into. One of the biggest concerns I had about some of the mechanical devices like the Inari device is when you're pulling things down, you shoot your venogram and you see clot all the way up and down. You run the clot retriever device and you come out and there's not as much clot as you're expecting to sort of see, and you sort of clean it out and you look and you got this beautiful picture. But a lot of the time I think what you're actually doing is snow plowing a lot of this clot into your profunda vein, into your hypogastric vein, and a lot of the time I think that's problematic. And so for me, that's why it made much more sense to go towards aspiration. I think also you leave the valves alone, you don't really have any issues related to that. So, I think the devices have advanced enough now where, going back to the thing about a tract, it used to be, I don't know which device works well. We don't have that problem anymore. The devices work great, even with acute on chronic or more chronic devices, whether it's aspiration or true mechanical thrombectomy. The issue is now we need a better trial to sort of know who we need to treat and what, because the devices work so well. I mean, there's a lot of times now with a aspiration device, you can treat an entire, iliac down to popliteal vein and put a stent, and it's a 30-minute procedure. I mean, I remember the days of that taking 2 or 3 days, multiple trips to the ICU. It's so much better.
Haven't you had problem with the jugular access with these large devices? No. It closes nicely.
Yeah, so I typically for jugular will use. I won't go bigger than about 16 French. For some complex IVC filter retrievals, we'll put an 18 French in there to use the bronchoscopy forceps, things like that. When you have filter-associated thrombosis, and I think for you guys here, the Optese is still on the market, so you guys probably know a lot about filter-related thrombosis, and so we'll do that. So we know that works fairly well. I put a little purse string stitch in just to help close the skin, but obviously no closure devices or anything, but a little purse string. For majority of the jugular, I use the 17 element sheath that goes with the aspiration catheter. Which is nice because you can shoot pictures through the actual sheath rather than through the catheter if you still have clot kind of engaged in there. So it works really, really well. I haven't had any knock on wood, haven't had any issues related to the jugular access so far.
Same here.
I didn't know you knock on wood in the U.S. also.
Yeah.
We do a lot here.
I'm glad it was right here. 'Cause, yeah, you say something like that and it's on something that's recorded. You're really asking for it. Yeah.
In Brazil, we got a German stent from Optimed available. That's the sinus obliquus.
Okay.
We actually use it a lot.
Yeah.
It looks very interesting for some cave anatomies. And the company in general says it's better for not thrombosing the other side. We also use a lot of regular stents, not the regular design stents. We didn't had some contralateral thrombosis. Do you experience any contralateral thrombosis?
Yeah, I think that we saw more with wall stent when we used to predominantly use wall stent. And I think closed cell was a problem. Yeah. And, the reported contralateral occlusion rate was 10%. I've seen some with even open cell stents. One of the big problems and one of the issues that we have in this whole segment is we don't have a good device that's an answer for the confluence. If you think about it, we don't really have one on the arterial side as well. We sort of pick and choose. But, we either are, leaving a stent that's pushing over onto the other side or double barreling or doing some sort of combination with these. And I don't think that's the right thing. I would hope in the next 5 to 10 years we develop a device that actually really deals with the confluence so that you can deal with the compressive nature of what caused the clot, but also doesn't compromise the other side at all. I think that's a huge area for improvement. And honestly, I think if someone developed that, they would get the market, because I think nobody wants to deal with the contralateral issues or size, and it would be nice, again, especially in a place where maybe IVUS is not as easily available or reimbursed, you wouldn't have to worry then about where that compression is, because you'd be well above it. Something that maybe involved both an IVC and on down system would be really beneficial.
And it's usual for the compression to involve the cava also.
Yeah,
I agree with you.
Yeah, it's funny when you do a lot of the IVUS, you really realize that the extent of it goes up beyond the bifurcation. And so you have, early on with the wall stent, the number one reason I would have reocclusions, the two reasons. One would be proximal not going above the compression, and the other was often being concerned about stenting across the inguinal ligament in the vein. And we sort of learned that doesn't really matter in the same way, and you have to treat, and we'll treat down to profunda vein if we need to, because it works fine, and especially with the newer stents, not a problem. And so it was really just not recognizing on the proximal side that the compression does extend up in the IVC, and a lot of times if you don't go into the IVC, you're just going to thrombose your stent. So you have to go.
After I started using IVUS, I noticed it's a huge difference between the radial force of the venous stents. Have you observed it also, and do you think about that when choosing the stent?
Yeah, I think it's really important to avoid oversizing it by a lot, because I think you'll get, a lot of pain and discomfort. We get, especially with a lot of the chronic recanalizations, ballooning and then stenting, often they get a lot of sort of hip flank pain afterwards. We usually have to give some sort of anti-nausea medication to folks as well for a couple days. They really feel it, and it's really annoying. It's really annoying. I think for acute thrombotic stuff, it's not quite as important, and really, you don't have to oversize a huge amount. You're really just trying to take that compression to normal size, and even if it's the same size as just your external, you're way better than you were. And so I think that often for chronic cases, we know from open venous reconstructions that sometimes big is not better. We really just need a nice channel there. So I used to try to really put as big as I could go in those chronic cases, and now very uncommon that I'm going, I probably do 10s and 12s more in chronic cases than I do 14s and 16s by far. But I think you do have to be careful. They work really, really, really well, and if they're oversized, they're going to get a lot of stretch injury, and it can be a big problem. There's some case reports of removing wall stents. I don't know if anybody removing some of these newer generation venous stents. That would be really problematic.
And which medications do you keep patients using after implanting the venous stents?
I think it's different for me if they are thrombotic or if this is chronic occlusion and they're having sort of venous symptoms. If it's an acute thrombosis, in general, I'm going to put them on both an anticoagulant, something like Eliquis, Pixaban, or and something like Plavix or aspirin. Probably have a preference more for Plavix than I do for aspirin in that case.
You use antiplatelets?
I do antiplatelets for a period of time as well. A lot of the time, once they've been treated from their, if it was a compressive symptom that caused their clot, and we've opened it up and repeat duplexes show that it's patent, somewhere in the 3 to 6 month range, usually I'll stop the anticoagulation and just keep the antiplatelet going. But again, there's no great answer in our data to tell us what we should do. I think if they're chronic occlusions and it wasn't acute clot, I think I generally do about 3 months of anticoagulation and then long-term. But I also, with chronic occlusions, I'm much more worried about long-term patency than I am with the acute thrombotic ones. It was just an iliac compression. And so in general, I'll take those people and downsize them on their Pixaban to maybe the half dose and keep them on that long-term as well. But again, that's in here. It's not, there's no good data on what we should do and what we shouldn't do. Even the C-tract trial for chronic occlusions only looked out to 6 months and didn't really do anything beyond them. We just don't know what happens long term with those patients. What do you guys do in those?
In general, anticoagulation with Varoxaban or Apixaban. But as you said, there is no good data, and sometimes it changes from patient to patient.
We had one associate that left us now in December, and he always did antiplatelets, Plavix together. But that's empiric observation.
In general, we treat for 3 to 6 months with anticoagulation. And I stopped after that without anticoagulant.
And do you usually do serial ultrasounds every 6 to 12 months from there?
Yes.
I usually, when possible, I leave the patients anticoagulated until something happens that they had to stop it. In Brazil, a young female want to do a plastic surgery, for instance, or they have to do a dental job. Then you stop it, and then if something happens, it's not your fault. But I usually don't stop the anticoagulants unless something of these kind of things appear. Mostly they don't happen, it's appear.
The one thing that we see appear a lot and we pay attention to is a lot of times, we have good apposition of our stents into the external. You've got a fixation point where the compression is, but sometimes in the common iliac vein, there's maybe not complete apposition because you're not trying to really oversize everywhere. We'll sometimes see that in those dead areas, just like you get mural thrombus in an aortic aneurysm, you'll get thrombus develop in there. And a lot of times people get very nervous and they think that the stent is starting to thrombose. Well, it's really not. It's just the flow around where that was. And so
we can have iliac veins with 22 or even more diameter and the iliocaval junction.
Another factor that plays a role here is thrombophilia. We always do a thrombophilia screening and to understand if the thrombosis was spontaneous or related to external factor. I think it's always play a role defining. Also, if anticoagulation will need to be used for life.
It's interesting that in general, if somebody has a first event and they have a compressive lesion, it's not really recommended to do a thrombophilia workup in the States. Now, a lot of people are so nervous that we end up doing it because they ask for it. And, some of the times you find stuff. And, I find a lot of times as well, a good family history when you're talking to the patient really helps you understand. There's a big difference between, I just knew it was my time. My sister's had a blood clot. My dad had one. All my cousins have had it. Those are the people where you don't even really need the testing. They're going to be on something for life. And, the problem is a lot of times that they have a pretty concerning history and they've had a thrombophilia workup, and you just know no matter what, you're going to keep them on a blood thinner, even if it's negative. And so it can be helpful. It sometimes, I think, gives a false sense of security to people, and I just don't think that we know of all the potential causes of thrombosis at this point clearly. And so, sometimes people are like, oh, well, it's negative. So they just stop the blood thinner on their own, and they don't realize there might be other factors at play.
Yeah. And talking about chronic occlusions, which is your primary approach when recanalizing iliac vein? Do you do which access, more than one access, which devices, which guide wire or catheter would be your working horse for chronic?
Yeah.
Because sometimes chronic work, it's hard.
Yeah. The hard part about those cases is you never know whether they're going to take 45 minutes or you're going to be in there for 4 hours. I generally like to do those cases under general anesthesia. I like to do them with IJ and lower extremity access. If they're, obviously if they're supine, sometimes I'll frog leg them, or I'll do a proximal femoral vein on the thigh for access. A lot of times, with imaging, you kind of know where all of this starts. And so as long as you can get a little bit of a runway, but I'll often try to come from both sides with that if I need to. There's nothing better than when it just passes from one side, but I think the hardest part is hoping you don't need both accesses and then wishing that you had both accesses. So it's easier just to set up for that. I try to avoid sharp recanalization if I can, but a lot of the time I find that just a good support catheter and a glide wire works the best. I sometimes will switch to an 018 glide wire, like a Glide Advantage wire, and that works very well. And so sometimes that works. We do have folks, our interventional radiologists sometimes will help us with sort of radiofrequency, sharp recanalization as well. I think the key for any of those cases is I find often something will go, you get a wire, but really IVUS is important to make sure you're actually where you think you are and where you should be. And so I think that's the key is I'll get a wire across and through, and then I'll do a small balloon dilation just enough to facilitate the IVUS catheter, and then I'll IVUS to make sure that you're not really, outside the vessel or in a small branch. You get so many of these strange collaterals in the area that sometimes you're in a collateral.
Yeah.
But I think once you've done that and confirmed IVUS, I'll serially dilate. And again, I'm not looking for normal vein size like you sometimes get on average, what we're 14s, 16s, 18s for stents on sort of post-thrombotic cases with compression. I'm looking more at 10s or 12s most often, maybe a 14 for compression. I don't try to oversize it. A lot of times they'll get good relief. But I think if you can get them open from an endovascular sense, they do so much better than an open PAMA procedure, something like that. I have a lady that I did a spine exposure on her, and she had a vein injury, and so I clipped and took care of the vein injury when I was in there, and then she had prior DVTs, ended up getting a worse DVT on that leg, occluded her iliac segment, did a PAMA procedure. It lasted, I think, a year and a half. It went down. I tried to do endo, and then I brought her back and was able to get through, stented, and now the stent's patent and open, and that's been open for 8 years now at this point. So it works much, much, much better, I think, than the open procedures that we had. So even a little bit of work at it is worthwhile compared to these open alternatives.
Switching to PE, that's a subject of great interest, also of a lot of discussion. And
it's a very similar problem that we just talked about in the DVT world. It's
yes.
Devices work, but who do we treat?
Yes.
Right?
And so, what are your thoughts about that? Do you think we have already an answer for that? Do you think? What about this new guideline?
Yeah, I think two parts about the guidelines. One is that the data that they used to make those guidelines ended in April of last year, which was prior to some of the newer data coming out, like the STORM PE trial, which was that first randomized controlled trial for PE in high-risk intermediate patients with a penumbra system. That wasn't on there. That was the first RCT in years. And so the data that was used and the new guidelines are not with the up-to-date data, which is always the way it works. And also, I think my takeaway from it was it now justifies what a lot of us has been doing and treating and how we've been treating for a while. And I think the second is that it does make the classification a little bit easier to understand. I think often, low risk and then this intermediate low risk and high risk and then these high risk, we're sort of confusing to people. And I think it's much more physiologically based in the new guidelines with the A through E. And I think really it's, A and B, and that's very low risk, subsegmental, asymptomatic, small stuff. That's the same management. You anticoagulate them, you send them home, you follow them as an outpatient. C and D is kind of where the bulk of where we're going to live is. And then E is sort of those who need to be at a place where you can get them on ECMO or systemic TPA. Those are those life-threatening. And so that C and D area, it does a better job of saying, well, how should you be evaluating these patients? What should you be trending with them if you don't go with an immediate intervention? How should you be monitoring them? And then what factors do you use to then justify treatment? And so I think they made the guidelines of moving from unfractionated heparin to Lovenox, and that was out of the STORM PE trial. The STORM PE trial confirms that decision because only, I think, a third of patients, by the time they were discharged in the STORM PE trial on unfractionated heparin, ever got to a actual treatment dose of their heparin, which is kind of scary. So I think Lovenox, enoxaparin does a much better job. And then it also says we should be getting imaging like a CT scan and getting an RV-LV ratio. We should be getting an echo if you can get one, which I think is very helpful. You should be checking lactates and other things to follow these patients. And I think it does a much better job of saying, okay, you've got someone who's potentially in that higher risk category. Let's see how they do, because I think you want to treat the physiology. You don't want to treat the clot. I get calls from the emergency room and they'll say it's saddle, and they freak out about the fact that it's a saddle PE. And the patient's on room air with a heart rate of 62 and they look fine, and it's really hard to justify doing something to someone like that, right? Because they handle that load on their RV much, much, much better than someone who maybe has a small amount of clot, but they look terrible. They're on 100% non-rebreather. They look terrible. Their lactate is high. Their troponin is high. And so I think that's the key, is that like what we talked about on the venous side, every patient's a little different. And I do think the guidelines here help a little bit with saying, who should you worry about? Who should you think about treating right away? And who should you maybe follow? One of the things that we've started doing is, it's easy to have someone that comes in from home who's functional, feels terrible, comes in, gets diagnosed with a PE, and then sits in a hospital bed and doesn't move for like 2 days. And you ask them and you say, hey, you're on the fence maybe about treating them. And you go, hey, how do you feel? And they go, yeah, I feel better. You go, okay, well, you still haven't, no, I feel a little bit better, but they haven't even gotten up in 2 days. So we find, get them up and walk them across the room. Try to get them up and get them moving. And a lot of the times you realize people just have no functional capacity whatsoever. And so those are people that generally will push to treat. And I think that's now justified in in those guidelines, which I think is helpful.
I think there is a great evolution from the latest guideline is creating more categories. Because one of the main problems that we had is to separate which population should be treated anyway. We don't have those answers yet. But I think it's if you start to define more categories to understand where to go, which tool would be better for each patient. I think there is a problem, with trial designs. Most of the trials compares intervention with heparinization, not with lytics And what do you think? What are your thoughts about when choosing between systemic thrombolysis or mechanical thrombectomy to C and D patients? How do you choose, or you prefer to do one of those treatments? What is your feeling about? Because we don't have the answers still.
No. You know, I mean, I think it's pretty clear from the guidelines that no C-level patient should be getting systemic thrombolysis, because I think that those two things just don't go together. And we know from prior trials that systemic thrombolytics have a high risk of bleeding. And so in that lower risk C category, we shouldn't be treating those. I think in the D category, that's where you start to think about it, and then obviously E, and that's where sort of in our world, we start thinking about availability for ECMO and some other life-saving categories. So really where you're looking is sort of C2, C3, and the early D categories for the people that we would consider doing catheter-based therapy, right? And so in general, I've moved away from lytic therapy with it, things like the ECOS and the ultrasound enhanced thrombolysis. The only times I will leave a ECOS catheter is if I have either trouble, getting through into the pulmonary arteries without sort of feeling like I'm maybe behind a chord A or some other structural heart issue, or in the people where if they're so tenuous that when you try to push a sheath up through the RVOT that they get unstable or they get an arrhythmia or some other thing, those are people that generally I'll kind of bail and just leave smaller catheters. But for the most part, I do majority of them now mechanical thrombectomy. And again, like on the DVT side, the devices work so well now that it's not really does that work? It's more who do we do it on? Most of those cases now, you can do those treatments in less than 30 minutes. I'll do them in our cath lab. I do those patients completely awake. I don't give them any sedation whatsoever because they're so tenuous to begin with. And then, generally one groin access. I've moved to, I use that 17 element sheath and the 16 flash device from Penumbra. And what I like is I used to do dual access. Now I can hook up the pressure readings to the 17 sheath that's in the PA, and I can run continuous pressures while I'm doing the device with the 16. You can also shoot pictures through it. So it's made it so much easier to be able to see what the pressure looks like as you're going. Because one of the big problems with PE intervention is knowing when to stop. So you can, we spent all this time talking about who needs the intervention to begin with, but how do you know when you're finished? Are you looking for an angiographic result? Are you looking for a physiologic result, meaning that their heart rate drops? Are you looking for their oxygen requirement to go down? Or are you looking for pressure drop in the PA? And so we sort of try to do all of those. But, if you're doing an intervention and the PA pressures drop significantly, but there's still a little bit of clot there, I'm done. I'm not going to keep going for time. I try to stop when I think the patient physiologically is better. And we know one of the great slides or data points from the STORM PE trial was seeing they had a CT scan prior to intervention and then they had one at 48 hours. They did not clear all the clot, and you don't need to clear all the clot. You just have to get enough out to change that RV physiology. So,
Martyn, thank you very much for participating here. It's a great pleasure to receive you here. We could stay talking about
I could talk about this all day.
about it for more hours.
Yes.
Yeah, it was very nice. And I would like to ask you for any final thoughts.
No, I just want to say thank you. I appreciate the opportunity to be on the podcast and to talk to you all, and I'm excited to be back in Brazil, and I'm looking forward to a little bit more sun in Rio than I've had this week, but hopefully by the weekend. But no, I think final thoughts related to what we talked about is I think we have devices at work, and now we need good trials to tell us who to do them on, and more importantly, who not to do them on.
Thank you very much.
Thank you.
Hope to see you in North Carolina.
Please come.
Been there in the 50s.
Oh,
My
yeah.
father went to Duke University for his master's degree, not
Very
in
cool.
medicine.
Okay. It's probably changed a little bit. You should come back
I've
and
been
visit.
Been there again, but
Yeah.
it's a good remembrance.
Oh, good. Yeah. Very good.
Okay.
Ok. Amigos, muito obrigado por assistirem mais esse episódio do Clube da Artéria. Curtam o sininho, nos sigam no YouTube e no Instagram. Muito obrigado e até a próxima.
Okay.